Okay, so it is with the greatest pleasure that we bring you the 8th lecture in the McGill Palliative Care National Grand Rounds series. With the generous support of 9, actually now 10 local hospital foundations and Pallium Canada, we intend that this initiative builds on the historic contributions by McGill University to the field of palliative care by providing a novel means to disseminate the latest innovation, research, and ideas in our field to places across Canada and beyond who may not typically have access to the types of speakers who typically present within the walls of our academic institutions. We are in a time of global turmoil, and because of this and some incidents on Zoom and other venues, we've disabled the chat. And so that means that I want to be able to provide some instructions about translated closed captions for people who may desire them. The first thing is to go to Show Captions at the bottom of your screen in the Zoom webinar screen. Make sure that translation button is switched on. Hover over My Speaking Language and select English today, and then hover over My Caption Language and select the language in which you would like to receive the captions. So I hope that that's clear, we will, if anybody has any issues, please troubleshoot with using the questions format. Before welcoming Dr. Stephanie Gingras to introduce this lecture, and before providing accreditation-related information for this lecture and the National Grand Rounds program, we wish to acknowledge the land on which this lecture is given.
Thank you, Justin. Bienvenue à tous. The members of this committee and their relevant declarations include Dr. Justin Sanders, who has relationships with La Maison Saint-Raphaël, the American Society of Clinical Oncology and Connections, Inc., and who has received honoraria and grants in recent years from the Oklahoma University of Health Sciences, the Oregon Health Sciences University, and Pancreatic Cancer Canada. Dr. Argyri Tsimikalis, who discloses a relationship with and grants from the Shriners Hospital for Children. Dr. Olivia Nguyen, who acknowledges an association with la Société québécoise des médecins de soins palliatifs and a research subvention from la chaire de la famille Blanchard pour l'enseignement de la recherche en soins palliatifs. Dr. Naomi Goloff, who reports relationship with the Canadian Society of Palliative Medicine and grants from the Kindred Foundation and l'Association québécoise de soins palliatifs. Social worker Zelda Freitas, who indicates grants and relationship with the Canadian Centre for Caregiving Excellence and with Nova Montreal. And Doctors Janelle Walsh, Oral Schuker, and myself, who have no conflict of interest to disclose. This series includes sponsorship from the Cedars Cancer Foundation, the Hope and Cope Wellness Center, the Jewish General Hospital Foundation, the Montreal General Hospital Foundation, the Montreal Neurological Institute, the MUHC Foundation, Pallium Canada, St. Mary's Hospital Foundation, the Montreal Institute for Palliative Care, a branch of the Teresa Delard Palliative Care Residence, and the Montreal Children's Hospital Foundation. A special thanks to the Department of Family Medicine at McGill for their in-kind support. Here we present a strategy to mitigate potential bias. The overall program learning objectives are as follows: to review innovative approaches for the implementation of palliative care in different settings, to assess strategies to address the most important challenges in palliative care today, and to appraise the latest research in the field of palliative care.
Thank you for your attendance, both virtual and in person. Our speaker for the McGill Palliative Care National Grand Rounds lecture today is Dr. Marie Bakaitis. Dr. Bakaitis is professor in the School of Nursing and associate director for the Center for Palliative and Supportive Care in the Division of Geriatrics and Gerontology and Palliative Medicine and the Department of Medicine at the University of Alabama at Birmingham, and co-chair of the Palliative Care Committee of the SWOG Cancer Clinical Trials Network. She has developed innovative methods such as telehealth and teleconsultation in palliative care to increase palliative and supportive care access for rural, underrepresented, and under-resourced persons with serious illness and their family caregivers. She has had a sustained and diverse NIH and foundation-funded program of research which includes persons with serious illness from cancer, heart failure, COPD, and cystic fibrosis. She has international collaborators in places like Singapore, Turkey, and Iran to bring palliative care to everyone, everywhere, every time it's needed. Dr. Bakaitis has published over 200 original database papers, book chapters, and books. She's a member of Cigna Nursing Research Hall of Fame, a fellow in the American Academy of Nursing, and a fellow of palliative care nursing. She is an extraordinary researcher and mentor, and I'm delighted that she could be with us today. So welcome, Dr. Bakaitis, and thank you.
Thanks for that kind introduction. And I want to say hello to everyone here in the room as well as on Zoom. I understand some of my colleagues in the US are watching from UAB. So, hey, y'all. Before I begin, I would like to declare I have no conflicts of interest. I wish I did. And that these are the competencies that I'll be addressing today. I'm going to go back to my learning objectives in just a second. First, I want to pay homage to my Canadian palliative care heroes pictured here, those who have pioneered the field, and I could spend my entire time discussing them, but I just want to take just a moment to expound on these individuals and the influence they have had in palliative care globally and on me personally. First, Dr. Balfour Mount, who is recognized as the grandfather of palliative care, passed away recently here on the unit named for him. And rather than a moment of silence, I'd like to give a moment of applause to Dr. Mount. Great. And then second, Dr. Neil McDonald, who was helped us at Dartmouth with our external advisory board in the 1990s to develop our first clinical palliative care program. He literally wrote the book, the Oxford text of palliative medicine. And Dr. Eduardo Bruera, who contributed greatly to developing symptom science in our palliative care field. In January 1999, I want you to recognize January, I came to Edmonton, silly me, to Dr. Bruera's program to observe how to provide comprehensive palliative care. And of course, my fellow, I still count you, Justin, as a Canadian, even though you're new here, and my fellow early palliative care researcher, Dr. Camilla Zimmerman. So I wanted to just acknowledge them. Let's see. Okay. So I came to rural palliative care kind of quite by accident. I was a city girl from near New York City. And also I went to school in Boston. And so it was pretty foreign to me when I went up to Dartmouth in rural New Hampshire, Dartmouth Hitchcock Medical Center in rural New Hampshire in the US. That I came to learn about this thing called rural palliative care. And although it was pretty idyllic, I experienced some serious personal and professional culture shock. I vividly remember attempting to send a patient home to discharge with this thing called implanted access devices, which were new at the time, and was told the home health care, they didn't do that, and we could not send him home. Shortly thereafter, a patient with lung cancer had pain managed only by an intrathecal pump. He also could not go home because they didn't manage that. And so I started to realize the challenges and the realities of rural palliative care. So I have to say that Although this vibrant picture of our UAB campus in Birmingham, Alabama is great, more often than not, this is where I spend my time in the 57 of the 63 rural counties that exist in Birmingham, Alabama. And so for some of you who might have to leave early, I'm going to start with my take-home messages in that rural palliative care inequities result from a perfect storm of older, sicker, poorer populations, medical mistrust, and very few healthcare or palliative care resources. But that if we are to realize equitable, effective, and sustainable rural palliative care, it's going to require us to increase access to palliative care principles and practices, but that's not going to be enough. We really need to focus on culturally adapting what it is that we do bring to our rural environments. This little diagram shows you that overlap, which is essential for that to occur. So now you can go do your email or whatever else because you've got the message, and that's what I'm going to expand on today. First, I'd like to start with a case, and this is Mabel. She's a 78-year-old African-American woman with newly diagnosed glioblastoma discovered after a tonic-clonic seizure at home. She lives in rural Alabama, but you could insert any rural place here in Canada that you would like. And she's a devout Baptist, widow with 5 children, 10 grandchildren, and 3 great-grandchildren, all of whom live hours away in the city. Her primary care doctor refers her to the Comprehensive Cancer Center, which is 50 miles away, and her family believes that she's going to get better care there. The academic oncologist there recommends palliative, radiation, and chemo for her inoperable tumor, and she returns home to pray and discuss this with her family. However, within a week of returning home, she develops a headache and vomiting. She goes to the local rural hospital emergency department and is airlifted to the cancer center. She assents to recommended palliative radiation because she's told it's going to make you feel better. And her family is unable to visit due to transportation and work issues. After a few days, she becomes febrile, confused, and experiences respiratory distress. And during a lengthy resuscitation effort, her physicians attempt to contact her family to understand now what her wishes for life-sustaining treatments were. And she dies alone in the ICU. Mabel's journey crossed many different environments, from the tertiary hospital, from her home, emergency, rural health care, maybe home health at some point. Certainly there was no mention of hospice. And where is palliative care? Typically located mostly in tertiary centers, sometimes in the community where there is hospice, as long as there is even hospice in those rural communities. So today I want to talk about some of the characteristics of rural environments that have created the disparities in palliative care, considering some approaches that can help enhance that access and acceptability, and discuss strategies to implement culturally based palliative care, some of our success stories. So let me begin with characteristics. As I mentioned, it's really a perfect storm of factors that make rural palliative care suffer from these inequities, including rural environments are typically those where there's persistent poverty, poor healthcare outcomes, often social injustice, racism. In the South, experimentation was huge and still plagues us in the rural areas. Broken treaties, what we call hit and run, where us researchers come in and try to do a great job, and as soon as the study's over, off we go. And trying to apply our one-size-fits-all that we've learned in our academic, mostly white, middle-class, wealthy, or middle-income places, and apply that to a rural area, which is a very foreign idea. And that leads to a lot of medical mistrust. We have limited health care at all, palliative care workforce, limited palliative care friendly health systems. So these are the conditions that lead us to having the difficulties that we face. Here's the United States, and what you see in green are the rural areas About 15% of the US population lives in these areas, but half of them are in the South, where it is that, that I'm from, we are working. And as you can see from the infographic here, although it's small, the bar graphs show you that median age is much older in rural areas, higher rates of serious health risk and conditions, so they're sicker and poorer, so a good portion are below the median income level. This is a lovely picture of the United States that was developed by the Center to Advance Palliative Care. And the states that you see circled there, or the states that are in orange and red, are the ones that have the poorest and lowest access to palliative care. Alabama is now a blue dot there, which is really exciting, but for years we had a grade of D. And you can see here that we consider the Deep South really a palliative care desert. Here's Canada. I'm sure you recognize this. And those little tiny purple areas are your official metropolitan boundaries where there's probably plenty of palliative care. The light green areas are rural, and the dark green are those sparsely populated areas where very little of the Canadian population lives. What I found is that you also have a nice set of maps, at least for two of the provinces, that show how palliative care uptake has occurred in these provinces. The first one to be published was British Columbia. And so what's circled there in red is a partially availability of services for palliative home care. And on the right is access to specialist level care support teams in hospital. And so you can see that there's a great deal of inconsistency here in Canada as well. And of course, these correspond very roughly to the most rural areas. The second one, and most recently to be published, is in the Ontario edition. And again, you can see areas that are circled there with low or minimal or absent access to palliative support in the hospital areas or in home care services. So I found these to be very instructive. Again, we have a lot in common between our two countries. In fact, there was a recent paper that was developed from an administrative database in Ontario. This was published in 2024 in terms of access to palliative care in Canada. And what this review identified was a significant gap in the provision of palliative care for persons near the end of life. Only 15% requiring palliative care services actually receive them in the year before death. Most of the palliative care visits occurred in the last month of life, which is the opposite of what we try to promote in early palliative care, and primarily in acute care settings as opposed to ambulatory. And more than 80% of deaths, though, could benefit from a palliative care approach. Now, I'm not picking on Canada because we have the same exact findings in the US, but I wanted to bring this home to all of you. Medical mistrust, which I've mentioned, is very rampant still in rural areas, and particularly in the South. A scoping review showed that this is also prevalent in Canada among racialized communities, Indigenous populations, and low-income groups. Historical discrimination and systemic racism were also prevalent. Misunderstandings about what is palliative care, and a lack of culturally sensitive communication and care models. In terms of family caregivers, a qualitative study showed in 2021 that there was mistrust amongst family caregivers as well. They felt unprepared for the amount of care they were going to need to provide in the home. They were frustrated with a lack of information, felt disrespected by the healthcare team when they didn't get their needs addressed or met, and that there was a mismatch between what they thought they were going to get and what they actually got. However, the bright news is that here in Canada, you've been very organized in terms of developing a framework for palliative care in 2018 and an action plan in 2019. And right now, it is our time to implement these things, many of which have already occurred in the urban areas in our rural areas. Let me tell you a little bit about Alabama, and so the area where I practice and do most of my research. So that's the state of Alabama, and each of those little sections are counties. As I said, there are 67 of them. The ones in green are the rural ones, and that star is where we are at UAB. And you can see we're in a nice, somewhat urban or metropolitan area, but once you leave the immediate area, there you go. This one is very disturbing. This shows in blue areas of persistent poverty. The definition of persistent poverty is areas where for the last 30 years, the median income has been below poverty level. So this low, the blue area, sort of that little band across the bottom is an area that is known as the Black Belt, based on the rich soil there, supposedly. And then this last one shows you, again, a reiteration in the Black Belt area. The darker counties are those that rank the lowest in health outcomes, from things like obesity, diabetes, heart disease. That's called the stroke belt as well. And so you can see the overlap of rural areas having these issues are profound. And so ironically, those are the areas that lack palliative care, and those are the same areas that probably need it the most. And that's where our target is. Similarly, this shows you our counties. Those green diamonds are where remaining hospitals are. The red diamonds are ones that have closed in the past decade, and the counties that have those stripes don't have a hospital. A doctoral student of mine did a survey of access to palliative care in Alabama, and one of the rural hospital CEOs left us with this quote. You probably already know this, but Alabama is one of the states with the most hospitals at risk of foreclosure in the next year. I think there are 28 rural hospitals, 60% are at risk for closure. And so here's what the face of palliative care looks like in Alabama. That little heart is the where UAB is. Again, the stars show you the hospitals that have palliative care. The green squares show the hospitals that exist without palliative care. And that was why we were responsible for having such a low grade and low access. Less than 40% of hospitals in the state have any palliative care services. Public hospitals, about 50% of them do. A little over 61% of not-for-profit hospitals have it. But look at that number of 4% in for-profit hospitals. It's crystal clear that this is not the love language. Palliative care is not the love language of CEOs in for-profit hospitals. We know that we are not a money-making enterprise. And so what I wanted to, again, show is that rural hospital closures are one of our most significant problems in expanding palliative care. Maybe some of you are familiar with this is the definition that CAPC, or the Center to Advance Palliative Care, has promulgated as the definition of palliative care. And all of it sounds familiar to you, but one of our taglines that we use to introduce this idea to our patients is that it's an extra layer of support, that we work with your existing healthcare team to kind of bring that extra expertise related to quality of life. So it was very easy to find a similar issue about the closures of hospitals here in rural Ontario. Communities were hit hard, and that was a very informative article. But my point for bringing this all up is that if we are to provide an extra layer of support, how do we do that in rural areas that have no layer of support to begin with? It's kind of like we're the icing on the cupcake, but there's no cake, right? And so how is it that you then effectively provide palliative care when this is the foundation that we're trying to build on? And it's sort of, for us, coined the idea of being too poor for palliative care. these are the things that we face. And now I'd like to sort of shift gears and talk about how it is that some of the strategies that we could use to enhance access and acceptability in these rural areas that face these challenges. One of them we're no stranger to in terms of access is telehealth. And I'm going to say a little bit more about this later. Also, home monitoring has helped some of us be able to recognize symptoms in people who aren't coming to clinic very often. And so these are implementing our technology-aided interventions is really important. And back, seems like a million years ago now, in 1999, Project Enable was our first attempt to bring early palliative care to rural areas. We built on the World Health Organization. This model should look very familiar to all of you. In 1990, WHO said we need to start palliative care at the time of diagnosis. They were referring to cancer, but it applies to other diseases. And so we were trying to test that idea because it was not an evidence-based idea at the time, and said if we did something at the time of diagnosis using Enable as the model, could we influence what happened at the time of death? Because clearly we found that when we were doing nothing or waited to the very end of life, death occurred with a great deal of suffering. So this is what we were trying to do. And because there was really no palliative care in the US at that time, when we were trying to look to Canada to see what to do, but we also asked our patients and our clinicians, what do you wish you knew when you were first diagnosed that would have helped you to cope better with your illness as it progressed? And so what they told us was what formed for us the foundation of Enable. And that was developing and maintaining a long-term therapeutic relationship, improving physical and psychological symptoms, including through learning self-care, assessing and enhancing the illness understanding and prognostic awareness, facilitating treatment and healthcare decision-making, planning for the future or advanced care planning, enhancing communication, leveraging local community resources and social support. They didn't want to be driving back and forth in snowstorms over mountains to get to the Mecca of the academic center. They wanted something that would help them in their communities. And finally, facilitating life reflection and legacy formation. So these were the principles that we put in, as we called it, our DNA of palliative care. And we usually think of these 4 quality of life domains. So these are sort of our base pairs on the framework of generalist and interdisciplinary specialist teams. And so what did we learn from there was no, and we didn't know there was going to be Enable 2, so it really wasn't Enable 1. It was our demonstration project. We learned that we could do it. We could do early palliative care in a cancer center, a rural hospital, and a community oncology practice. And that we measured a lot to see how that went. And compared to our local and national benchmarks, clinician and patient goals of care communication were increased, as were advanced directives, home deaths, hospital use, and average length of stay increased. And there were decreased hospital and nursing home deaths. All of that was super great, except we had trouble getting in touch with people because our first demonstration project required them to come weekly for 4 weekly sessions to sort of learn these principles. And so we ended up doing almost half of our sessions with people by phone. And so when we went to do our randomized trial, our next trial, we said, well, we just need to build it in, that there is the phone option. And that's kind of how that came about. And so we talked about, we did have in-person visits that people could come to, but I have to say those were poorly attended, and most people took advantage of the phone option. And what we delivered was, again, for the in-person piece, a comprehensive palliative care assessment was something that we were just learning to do. But by phone, very skilled, trained palliative care nurses used somewhat of a curriculum, which we called Charting Your Course, This is a later version of the booklets. Were 6 sessions, and all of those basic principles of palliative care that I mentioned were incorporated into these 6 sessions. And then after these were done, we followed them up for 48 weeks. And this again was in our trial, our second trial. And what did we learn? Well, it worked, right? So ENABLE, by the way, I don't know if I said, it stands for Educate, Nurture, Advise Before Life Ends. And we tried a lot of palliative care interventions beforehand, but we never got funded till we had an acronym. So there's a lesson for you. Come up with a good acronym. That's what gets you funded. I'm joking, but the coincidence is real. So in our first randomized trial of early palliative care using the ENABLE model, we found that patients who had early palliative care, this was all cancer patients, had improved quality of life, mood, and there were trends toward improved survival as well as symptoms. This was in 2009, so it sort of predated, Dr. Temmel's study, which I'll mention in a moment. In our next study, we could not ethically provide palliative care versus a no palliative care arm. And so we were testing sort of the early versus later phenomena. And there we found that although there were no differences in patient-related outcomes, that's probably because our cancer center was so used to patients getting early palliative care that before the late people were supposed to get it, they started early, so we had a lot of contamination between the arms. But the early patients did have improved 1-year survival again. In that same study, we offered a parallel intervention for family caregivers. They had lower depressed mood, lower stress burden, and a trend towards improved quality of life. And so this was great, except people love the idea that early palliative care, was going to benefit all of these patients until they learned that it was by telehealth. There was a lot of skepticism that you could do this high-touch care model by telephone. But the data, and the results are the results. Last year, we were vindicated in that Dr. Temmel's group, through a $10 million PCORI study of 22 sites across the US, UAB was one of those. The program was called REACH. They tested telehealth versus in-person early palliative care for patients with lung cancer, and thousands of patients. And what they found was, you see in the box plot, that there was no difference. Telehealth was not inferior, and there are actually some advantages in qualitative data that patients identified, as well as their family caregivers, in terms of driving back and forth to appointments and so forth. The first graph with the box plots there, where video visits are in orange and in-person visits are in blue, shows you that over time, quality of life measured by the FACT-L was increased, but there was no advantage in one method of palliative care delivery versus another. And similarly, in the box next to it was anxiety. The anxiety measure shows similar outcomes from both. And so you can see that it's very clear that, all the other measures, by the way, I was just showing you these two were similar between the two methods of delivery. This is great news for rural palliative care, because it shows that there is not a need to be coming to clinic all the time. And for them, they were doing video visits for sure, but many of them, because patients didn't always get through the video, had converted to telephone. And I know because at UAB, we had that similar situation. So here was finally the evidence that was the head-to-head comparison. In addition to things like telehealth or technology aided, is diversifying the workforce. And so here are 3 ways in which we in palliative care can help expand our numbers, because specialists are a little bit scarce in the big picture, and especially in rural areas. Primary palliative care education is one way, whereby palliative care principles are brought to specialists. We've just finished a study in hepatologists, where we trained patients with end-stage liver disease, their hepatologists, how to do palliative care, and compared that to specialty referral for early and for end-stage liver patients, sort of early in an ambulatory setting. And, spoiler alert's not published yet, but there was an abstract that showed Palliative, this method of care, was equivalent. Lay navigators and developing community workforce, and then leveraging other members of the interdisciplinary team outside of specialty trained physicians and nurses are ways that we can improve access. And here your very own Dr. Sanders led the palliative care update guidelines from the American Society of Clinical Oncology. And there's the QR code, so if you'd like to see the entire guidelines. But one important piece of that was the primary palliative care increasing access via to a palliative care workforce, and sort of compares and contrasts what the primary palliative care clinicians do in comparison to specialty palliative care. And that's a lot of really important work in rural areas, for sure. I want to switch now to the culture issue, and to say that, we learned a lot in our first published JAMA paper and our second paper, and showing improved survival. And so we got it right. What we didn't get right when we tried to implement this in the culture of a clinical trials group. I'm here to tell you that we have, COVID was a big factor, no issue about that. But this QR code will bring you to our cluster randomized control trial of implementing early palliative care in community settings, many of them that were rural. However, a clinical trials network was developed to give new chemo, investigational drugs, radiation, and trying to do a behavioral trial was very difficult. And so our lessons learned paper of not paying enough attention to culture will be coming out shortly. We weren't the only ones that had to learn again the hard way. Dr. Jennifer Temmel and her advanced lung cancer study, again, had shown wonderful benefits until she tried to spread that through a clinical trials network. And here's a QR code to their wonderful paper that shows they weren't even able to complete their study. And this pitfalls and prospects, lessons learned of early palliative care shows you. And so what I'm here to tell you is culture eats strategy for lunch. We could think we know all of the important implementation strategies, but if you are not paying attention to the culture of the local community and incorporating and engaging them and having that inform your work, you will fail. And I've learned that many times now. So let me talk to you in closing about how we had learned the one time or one of the times we've learned to do it right. We did first a review of the literature and found that providing palliative care to people with cancer in rural and remote areas, that there were sort of three major themes. One of them is that there's often a clash between the culture of palliative care and local healthcare providers. We talked about how developing community partnerships were essential. Inattention to religion and spirituality is another issue, and partnering with spiritual leaders and leveraging how religion and spirituality can reinforce culturally appropriate palliative care is important. And also from the literature, having local healers who have a powerful influence on illness care. If you do not partner with them, you can, again, just forget it. Some of these lessons we have put into practice. An article from Health Affairs about bringing palliative care to rural underserved communities was published now a few years ago. And the major solutions that we had been using or have been using successfully at UAB included those technology-enabled solutions, and more importantly, these community academic partnerships. Sorry. The But we had a question about, we've been doing this outpatient and we've been developing these situations, but we were wondering if it was possible to bring specialty palliative care to small rural hospitals for seriously ill patients. And we developed a study shown here, and the QR code is there, called Community Telepal. Now, I want to tell you about the four of the main strategies that we use to help us figure out how to do this right. This again was in rural areas. I've oriented you to a lot of the rural South. And so the three rural hospitals were located in Mississippi, Alabama, and South Carolina, again, in very rural areas. And we had invested early in a project led by my colleague, Dr. Renee Elk. I was a consultant on this project. And so working very earnestly with a community group to help inform how was palliative care going to be seen as acceptable. In the focus groups, they told us a lot of what we needed to do and how we needed to approach it. Here's one quote that said, "Death and dying has a lot to do with our faith. If we believe whatever the words say, it has to do with our faith and our culture and our community at large. Remember, we went to the church for everything. Church was the leader of everything." And again, this gets back to what I was saying in terms of connecting with the spiritual leaders in the area. We took that information from the focus groups, and we were looking specifically at a rural, older, white, and Black population. And some of the themes from an African American focus group are shown here. We take care of our own, the family takes care of our loved ones, hospice equals death. And how we applied that to the palliative, the culturally informed palliative protocol is shown here. We would not routinely bring up the topic of hospice early on. We would explain it as help at home and not there to help with dying, and that these people are there to help you, not to take over the care. The second thing was that early focus community advisory group actually trained the physicians who were going to deliver the culturally based palliative care intervention. This is Miss Gardenia from a group of the Gullah people, which is the early colony of slaves that came over. They're all related to them. And we went there for an immersion experience so that all the team members could understand exactly how these things should be presented. And this article will direct you to those details. The second thing we did was have community advisory groups at each of the small hospitals help us with patient-friendly materials. And also for those members said to us, look, we're the ones in the local community. We want to talk to our local community members. And so if you let us help you with recruitment, we will, we'll do that. So I'm going to share with you this 1-minute clip of a video that one of our community members made, because during COVID, they couldn't physically go in the hospital. And so they made videos for us to bring in to kind of substitute for them introducing the study.
Tiffany Perlow, and I'm from Barnwell County. I currently serve on the Community Advisory Board there at Aiken Regional Hospital, where it's a group of people that look like me and some people that don't. Men and women, Blacks and whites, working together to speak with the medical community about how to implement cultural sensitivity within the medical system. I apologize today that you suffer from a chronic illness that has you not feeling your best, but I would like to strongly encourage you to take this opportunity to participate in the study that will help us gain insightful information to pass on to other patients and their families who are suffering from illness, and improving that communication between doctors and nurses and patients and family members during times like this. I'm glad to serve on this board. I appreciate the opportunity that you're providing me to speak to you today, and I pray that your condition improves. And I also pray that you will allow us to collect the information that we need in order to better help people in our community who suffer from illness such as yourself. Thank you for your time and the opportunity to speak with you.
I always get right off the eyeball staring. Like, who could say no to that, right? One of your neighbors comes and tells you, a respected member of the community that gives health advice. And so, this is sort of the ultimate really in engaging with communities. We were rewarded by bringing this up, being able to recruit even during COVID, the number of patients we needed, and showing that in this box, the lower arm is the video consultation arm. That symptom distress was lower in that arm in these patients in the small rural hospitals compared to their usual care. This isn't magic. This formula of cultural engagement or community engagement has been successful for us in Iran. So this is my colleague, Arvin Murshahi. I don't know, Arvin, if you're watching today. And they translated linguistically, culturally, the Enable intervention into Persian. And have been testing that there. And my colleagues from Singapore, Dr. Grace Yang and Dr. Shirley Neo, that means I'm supposed to stop, and I'm just about done. They translated it into Chinese. So my main message is that cancer mortality was reduced by 25% with no new treatment advances applied, but except for what we currently know, and applying them to culturally underrepresented people with cancer. And so the question is, can we have similar outcomes if we apply just what we know in a culturally appropriate manner? Well, I'm going to look in the crystal ball and I'm going to tell you how this works. So going back to Mabel, we'll end with Mabel. And we have now implemented all of these things in a culturally appropriate way. And you remember Mabel's diagnosis. However, because of the distance from the cancer center, she's enrolled in a palliative care telephonic program. Her coach coordinates with her local doctors and community resources, and her son has a lay navigator, family support coach available. And Mabel learns to have conversations with her family about her wishes, advance directives, and identifies her son as her healthcare proxy. Everybody knows them. They're in their medical record. She opts for palliative treatments in her local community for symptom management instead of going to the cancer center 50 miles away. However, the cancer center has a video consultation program, and a palliative specialist meets with them, and they devise a support program for home. She continues to participate in her valued church activities. Her congregation helps and prays, brings her meals, so she doesn't think she's getting better care someplace else. The family has video visits with the local healthcare team, the distant family, so they're all on the same page. They're able to reminisce, do life review. And so she's in the home of her family. When she gets symptomatic, she contacts the nurse coach who has activated the emergency plan that was prospectively developed, providing rapid symptom relief and home hospice. She no longer dies in the ICU alone, but in the comfort of her family with hospice care. And because her wishes were known, when you call 3 and 6 months later to do bereavement, they tell their friends, they thank you, and then they tell all their friends and their congregation about the benefits of telepalliative care and hospice for their ill family members. My take-home message is, as I've said, that we really need to increase access, but that's not enough. Cultural adaptation is key, and I want to thank you for your attention.
Thank you, Mary. We're going to take some questions and comments. First, are there any questions and comments in the room? Okay, we have some questions here. Can you say something about the role of compassionate communities and their potential impact for rural communities?
So you're going to have to tell me what compassionate communities are in Canada.
I think the question online is referring to the sort of movement of compassion, the compassionate community movement as a way of building infrastructure in communities to, I think, attend to each other. I'm actually not an expert on compassionate communities. Perhaps the person who put in the question can put in a good. But I know that there's an increasing evidence base for the role of compassionate communities in improving care. So I think that was where the question came from. While we're waiting for that person, maybe we have another one.
When you compare non-specialist palliative care to specialists, is there a danger that when you find no difference, you undermine the work that's been done to show the value of specialist palliative care?
That's a great question. And the answer is no, because what primary palliative care does is teach you the basics. And one of the basics is when you're out of your league, refer to the specialists. So it doesn't really replace, it extends what it is that we can offer to many people, and that you know enough what you don't know. If we've done primary palliative care teaching right, you know what you don't know, and that's the point at which you refer. So again, it's an expansion. It's not intended as a replacement for palliative care, but that's a great question.
Thank you. What have been the biggest challenges in implementing the Enable intervention in rural settings, particularly regarding limited healthcare resources or workforce, and how have you addressed these challenges?
You know, that's another great question. And I don't know that we have addressed them all, because this model has a centralized workforce of palliative specialists. And again, so, you know, you are remote. There's a lot of, uh, you know, being present, you know, going there and establishing those relationships before you're trying to do this. But I do still think there are major gaps, and that concept of being too poor for palliative care is a real one. You know, we would meet people and try to have them, you know, utilize these various, you know, ideas of doing, you know, advanced care planning and how are they going to do these things in the home. But there really wasn't anybody there to rely on. And so, you know, it's a challenge, and we have not, I would say, overcome that. On the other hand, there's been a lot of education and prospective development of resources. So like the case model at the end, anticipating that things could go wrong in serious illness, emergencies can happen, and how do you plan in advance for those things to happen instead of just denying and hoping for the best? You know, we're planning for the worst. So I think that the nurse coaches were integral in making sure that patients and their family caregivers, you know, had tools, had they learned. You know, we had how to be a partner in symptom management was one of the things that we taught. How do you communicate with your clinicians so you get the response that you need to your biggest problem? And so that type of education, I think, was really helpful. And prospectively learning what's in the community and being able to activate those resources quickly. I think those are some of the successes.
Thank you. How should health systems most effectively respond to your body of research?
I'll tell you one anecdote. When we were going to talk to we talked to the president of the hospital, of the local rural hospital in Alabama, and we were trying to explain, you know, palliative care, and we were approaching it the way many of us do, like it's going to save all this money, patients aren't going to go to the ICU, and they were very skeptical because that's where they were making their money. And so they said, like, that's real cash. You know, cost avoidance is not a thing for, you know, it doesn't sell the idea. I told you, it's not their love language. And so, you know, we had to convince the CEO before he would let us do that there, that we were going to help get people, you know, who were tying up your very nice, expensive ICU beds moved along so that you could get, you know, new patients in. So we really had to change tact in terms of that convincing. It's not the standard of care throughout the United States, so we haven't been successful yet in implementing Enable throughout, or a model like Enable. But, you know, I feel like we've learned a lot in terms of how to make it happen. I don't know if I've answered that question.
Yes. Why are the hospital closures so prevalent in Alabama?
You know, I just gave you the idea of Alabama, but actually nationally, it's a huge issue. because they can't stay solvent. They can't find people to staff them. It's just, there's been, kind of a consolidation of larger hospital and hospital systems buying up some of the small ones. And if they can't turn a profit by using them for like surgeries and other profit-making procedures, they go under, or they really shift to, doing those kinds of surgery. So I think it's really the healthcare system itself, but I'm not sure what the answer is because, as I noticed here you have the same issues, again, with hospital closures. So, I think that we need to prioritize healthcare as a right and a service as opposed to a business. And I think because of that business model, and those small hospitals not being profitable, but just doing good things for their communities, they're closing.
And last questions. Any thoughts on whether any role for artificial intelligence in rural palliative care?
Wow, you saved the best one for last. There's a long answer to that, but the short answer for me is I have to learn a lot more about the ways that this can be beneficial to us in palliative care. I think there's been algorithmic models that have been developed to see like who would be the highest, benefit the most. I don't know that I like or trust those models in terms of depending on that kind of thing. But I think that's sort of, a very low level, immediate, uninformed way to think about how AI can help in rural areas. So thanks for the question, and I'll get back to you.
Thank you so much.
Everybody's trying to figure out what to do with AI in healthcare, including palliative care. So this concludes the McGill Palliative Care National Grand Rounds Series lecture. We're so grateful to Dr. Marie Bakaitis for her expertise and her time with us today, and we're grateful to you all for attending both in person and online. We ask that you please complete the evaluation form that you can access with this QR code and that we will also send to you soon by email.
We look forward to seeing you again on November 19 when Dr. Laurie Wiener will speak at the Montreal Children's Hospital. Thank you, everyone, et à la prochaine.